Yes, please go ahead.
Good morning, PV sir. Thanks for this opportunity, and my other teacher, Dr. NSS, and good morning, and everyone, all friends. So I'll be defending my talk. It's visible, sir?
Yes, yes.
Yeah. So this is anti-VEGF monotherapy in PDR. As Dr. Vinod said, PDR progression can be stopped by doing anti-VEGF. Earlier studies, Rise and Ride study showed that despite giving 24 injections, 10% of the patients went on to develop PDR. In protocol also, almost 20% patients went on to develop PDR despite giving repeated intravitreal injection of anti-VEGF. And as far as the panretinal photocoagulation has been concerned, even data from ETDRS has shown over a follow of 16 years, 42% patient maintain vision of 20 by 20 or better, or 84% had 20 by 40 or better, showing clear-cut role of laser photocoagulation in PDR. And this was an interesting protocol S, which was done for 2 years and extended to 5 years. In this, only 67% of the patient, they had a follow-up of 5 years. And visual acuity in eyes which received monotherapy or the patient who received laser photocoagulation, the treatment effect was same. Even it was said this anti-VEGF treatment is non-inferior, means it is not superior. And if you look at the results in protocol S, 2-year results are comparable, DME status was improved, and there was a better preservation of visual field. But if you look at 5 years as shown by protocol S, the visual field loss was comparable in both the groups, which was a major outcome of this study. But looking at the potential short-term benefits of anti-VEGF, you are going ahead with a significant cost and treatment burden on the patient. Another study by Boyder and Todani associate showed that area of capillary non-perfusion remained same, rather worsened, despite giving anti-VEGF injections. So basically, the whatever improvement you are seeing clinically, it is a sham. It may lead to complacency and maybe lack of close follow-ups, leading to more worsening of diabetic retinopathy in such patients. And also, it has been seen that once you stop anti-VEGF medications, approximately 30% of the patient, the retinopathy again will worsen. And whatever comes back, it comes as a bounce, and the progression of diabetic retinopathy is much worse if you treat with laser photocoagulation. Another side effects of anti-VEGF are intraocular pressure rise, endophthalmitis in few cases, and even the risk of TRD, which you may not be able to see sometimes, and it can lead to retinal detachment. And also treatment interruption can lead to significantly greater number of eyes with TRD and neovascular glaucoma progression as a rebound phenomenon. And PRP laser has a good regression of the disease as shown by ETDRS and other protocols also, and stability over a longer period of time. So if you look at Indian scenario, you are putting the patient to expensive therapy where most of the patients, they are not covered by healthcare support from the state level, and they are depending on their financial health only. And also follow-up compliance is as such poor in Indian scenario, and need for monthly injection, and then keeping a record when to visit a doctor is quite challenging. And whereas you are able to do laser comfortably in 2-3 settings and making the patient safe. And even the phobia of multiple injection is always there. Patient starts to run away, and risk of endophthalmitis. And another thing, this is still progressing despite such expensive treatment. So your compliance is poor, expensive therapy with no health cover, additional risk of injection, phobia of receiving injection. So all this, I think it doesn't warrant giving anti-VEGF injection in such scenario. And PRP is a gold standard, and it is cost effective, completed in a few office visits, and the long lasting effects. Yes, anti-VEGF can be reserved in few cases where you are planning to do laser, not able to do laser because of vitreous hemorrhage. You can want to wait for the vitreous hemorrhage to clear. So this can be but it cannot be a monotherapy. So a big no for anti-VEGF monotherapy in PDR cases. Thank you very much.
Yeah, again, you're going as if old is good. Neeraj, no, excellent presentation. Over to Mona.
Can you stop screen sharing, Dr. Neeraj?
Yes, sir.
Yeah, are you giving 1 minute time for Vinod to rebuttal?
Vinod, you want to say something?
For 1 minute, you have Vinod.
Ma'am, as I told, no, it's very difficult topic to defend as of now. But I think we go back 1 decade and we all used to laser, and I think hardly we do macular laser nowadays for diabetic macular edema. So the same thing is going to happen. The only thing what is probably going to change is we are going to treat these patients earlier in their treatment, probably at this stage of NPDR or severe NPDR or very severe NPDR.
Okay. So thank you, Neeraj and Vinod, for debating on this topic that I'm sure we'll hear more of in the next few years. I think all of us were skeptical when we heard of anti-VEGF monotherapy for PDR in the past. And now with the results coming out, we are learning that maybe there is a small role somewhere. If we look at the initial data of 2 years, everything was very nice. When we look at protocol S 5-year data, we see what Neeraj mentioned, the dropout. The question, the significance of the dropout is because this is proliferative diabetic retinopathy and not macular edema, because macular edema rarely blinds people, whereas untreated PDR can blind people. So I think that is the one difference between the two and the importance of the follow-up. But if we dissect out the protocol S data, we realize that patients with moderate PDR did good at the end. Patients with very high risk PDR did not do as well. Patients with associated macular edema did better. And the study Neeraj showed us, which probably is a little bit of real world that we see, is that loss of follow-up is a big issue with high risk PDR. So to conclude, I would say both have their roles. Definitely, if you see a patient with moderate PDR and macular edema that requires treatment, there's still a role for anti-VEGF therapy. But we know there is the crunch effect when there is fibrosis, when there are mature vessels. We know anti-VEGF will not cause regression, may worsen the traction. So I would say still each has its role. And in our Indian scenario, I would say more than 50%, we would still want to think of PDR with a few selected cases where rather than laser, we would give anti-VEGF. So well done, both of you.
Thank you, ma'am.
Thank you, Dr. Mona. The